Sir, I'm not speaking on a keloid, so I'll try bring a different dimension. So just wanted to see the impact of what these families have to go through if they have a child with a congenital corneal abnormality. Again, I thank profusely Dr. Deepak Edward for a brainchild behind this particular project, and I learned so much from this project. So globally, it is estimated that vision impairment costs about 168 billions annually productivity. So the corneal blindness seems to be one of the greatest economic burden. The reason is, the corneal abnormality not only have an early onset, but also one lose significantly more productive years due to the disability associated years. So therefore, the timely and a cost-effective intervention is a key in minimizing or mitigating the blindness related to the. We have several publications from our community ophthalmology. They have screened, extensively a lot of RAP studies, and what we found about nearly 11% of all children in a blindness have had a corneal abnormality. In the Western Maharashtra, they have showed about 22% of all children in the blind school had a preventable corneal abnormality. It could be acquired, it could be congenital, and once a child has such a defect, so it is beyond the physical disability. It may cause a psychological, emotional, socio-economic challenges. I have seen in my own practice there are several families which were broken thereafter. They have an incurable blindness in a child. Okay, because the parents may not accept. They tend to go through a different turmoil and tend to have a denial, blame, so on and so forth. And we were trying to see how these families cope up. And based on some of the studies, not only these are the various prevalence of etiological agent causes of childhood blindness. It not only directly impact the child's education, and eventually they have a limited employment opportunities and overall reduced quality of life. So we just wanted to see how it dallies in terms of it impacts not only child and the family. And as we know, and both elegantly presented by Dr. Radhika Tandon and Vanati, diagnosis directly impact anatomical outcome. There are certain conditions which have extremely poor outcome, certain have extremely good outcome, like a type 1 Peters anomaly, CHED. We have well over 90% 10-year graft survival, as against sclerocornea, keratomalacia, and a type 2 Peters anomaly have a abysmal poor. Oddly, handful of cases can maintain a corneal clarity after 1 year. So determining the visual potential, that is a risk of amblyopia, which determines functional success. We don't want just to have a clear graft. Child should see through it. It does impact the functional quality of a child. And presence of ocular comorbidity, as Shushmita was rightly pointing out, particularly glaucoma, aphakia, they can actually affect the longevity of the graft. And one of the most important thing is the judging ability of the family to participate rigorous post-operative follow-up through and a visual rehabilitative journey is a key for a overall keratoplasty. So the very premise of our work is based on this last, the socio-economic. I think more than anything, I think this is one of the key indicator for a longevity of the graft. In the interest of the time, I will just only go to the results. It was an online survey calculated, did with one of the freely available application. So what we did is, I'm sorry. Yeah, we interviewed about 255 families and slightly male preponderance and nearly 86% over the telephonic conversation, and 35% of them were acquired, remaining are all congenital abnormality. And most of them they reached after the referral, meaning 90% of them had a prior intervention or a treatment diagnosis elsewhere. And when they presented, average age is around 4 years, and at the time of interview 10 years. And if you look at geographic distribution, mostly from southern India, then the western part, and also some of them are a northeastern part. Wherever, parental consanguinity is much higher, where congenital abnormality are much more, and elsewhere, particularly Bimari states, wherein you have an acquired, right from keratomalacia, trauma, injury, and so on and so forth. So about 40% of them are joint families and single mother. These are the subset where we had a extremely difficult for a follow-up, and they have a poor accessibility right from the water, transport, and primary health care. And many of them were traveling, more than 500 kilometer only, because of financial constraint. Nearly, 26% of them did not come for a follow-up. That means, eventually these grafts will succumb. Whatever, maybe the etiology, the effort we have put in, approximately 40% of the families, and they are much beyond 500 kilometer. That means, travel expenditures, loss of income, wages, and so on and so forth. And we did use a Kuppaswamy modified social economic scale for the current year. And this again elegantly shows with higher disposable income, they tend to opt for a paying category, whereas nearly two-thirds of them lower to lower middle socioeconomic status, where LVPI has a provision to provide absolute free treatment. And of course, they have to take care, medications, travel, many other issues. Nearly, as I said, two-thirds of the families are lower socio-economic. It's not only affect the child in terms of, education, clothing, vacation, and also the family. Family have to forego all the recreation, better food, social gathering, and a proper nutrition. It does impact the other sibling as well. And nearly, it is one of the noteworthy findings. 60% of these mothers have to quit the job to become a full-time, child caretaker in all these cases which had a keratoplasty. And a child, if they have an impaired vision, none of these children have a 20/20 vision. They have a good ambulatory vision, yet, for a schooling, for other things, they did have a difficulty where one of the parents have to really help them. So what our study actually shows that, majority of them low income family, they may have a lower education and a lower, disposable income, and makes, it is a very difficult. Nearly 40% of them, end up spending 54% of their annual income on a child's care. This actually deprives not only the family's resources and also on other child it, impacts. And majority of the cases where we don't have any government support. And again, losing working mothers who have to give, sacrifice their career can also directly impact the family. So the key message is that, we don't have, preventive measures. We don't have a robust, fetal registry in India to document every defect, and don't have a proper access to the genetic counseling. And overall key is, just to alert the advocacies, see that, we have some, stringent, robust measures in place. I think prevention is much more important. And that was the key message wanted to give from this particular study. And also, we need to strengthen the system to support financial aid to such families to cope up. It is really difficult for the lifetime, for the family and also child. I thank all my collaborators in putting together this project. Thank you for your kind attention.